Welcome to this edition of ESO TV, Midday Highlights. I'm Peter Kelly, ESO past president. I'm here with my co-moderator, Annemijn Algra, and our esteemed guests, Diana Aguiar de Sousa, welcome, and Valeria Caso, very welcome today. So we've just come from an absolutely wonderful first plenary session of ESOC, a fantastic mix of different studies, different trials, different themes presented. And we're very fortunate to have one of our presenters with us this afternoon. Diana presented her work on CVT and provided us with some really wonderful new information. So Diana, could you tell us a little bit more about your study?
Thank you very much for asking us. Yes, so this trial is a cluster randomized trial on the duration of anticoagulation after an episode of cerebral venous thrombosis, in which there is no indication has decided by the treating physicians to do permanent anticoagulation. This trial, this cluster randomized trial, was complemented by an observational study, prospective, with a similar design that patients were also allocated either to a short-term policy, which was defined as 3 to 6 months of anticoagulation after the episode of CVT, or long-term duration, which was defined as 12 months duration of anticoagulation after CVT. So overall, the study included more than 1,200 patients, with 460 in the cluster randomized trial and the remaining on the observational study. And yes, we could have some interesting results as well for this first 12 months of follow-up.
Okay, so what were the main results?
Yes, so the study has a 24 months follow-up. We are here discussing the first 12 months, which is the period where the two policies differ, and we can directly compare the groups of patients that were on the short term and stopped anticoagulation and on the long term and were all the time under anticoagulation on an intention to treat basis analysis. And indeed, we couldn't find difference on the recurrence of venous thrombotic events across the two groups, both in the cluster randomized data and also on the observational study. Actually, all results are very consistent. Also, we couldn't find differences in terms of the major bleeding and also on the composite outcome of major bleeding and venous thrombotic events. Interestingly, we found numerically higher rates of death and vascular death in patients on the long-term policy, and this was also consistent both in the cluster randomized trial and in the observational study, although the adjusted analysis for possible confounders was not statistically significant, the difference between the groups. So overall, we believe this is important data that should be used and considered when doing the specific and individualized decision on duration of anticoagulation with patients. Of course, this should be tailored to the specific situation, but this is an indication that at least we couldn't see an early benefit of an extended duration of anticoagulation, and there's possibly a sign of increased numerically higher rates, at least, of death in these patients that are on the long term.
Yeah, fantastic data. One of the things that really impressed me about your study was the global reach of the countries and the hospitals that you had participating in it. So how many countries did you have participating? And related to that, what was the breakdown of anticoagulation use in the CRT, in the cluster randomized trial?
Yes, so we are very happy that indeed CVT is a global disease, and indeed the participation is also very representative. We have centers in India and Mexico and many regions of the world, also a large proportion of patients coming from middle-income countries, together also with high-income countries, in many European participants as well. But this shows a better representativeness of the trial, and also we hope better generalizability of the results.
Absolutely, yeah, completely agree. And
yes,
what about the anticoagulants then?
Yes, so there's still differences, and that's why we included the country income and the type of anticoagulation and cryptogenic CVT, age, sex, and in the adjusted analysis, because there are differences. Of course, patients that come from middle-income countries more often are treated with vitamin K antagonists.
Right.
And indeed, some of the bleeding complications, indeed 3 of the vascular deaths that occurred in the trial were associated with VKA, were patients on VKA. And these patients were younger, had more severe presentation. These patients coming from middle-income countries were younger, had more severe presentation, more often more brain lesions, and more often were treated with VKAs, while patients from high-income countries were older, more often females, more often treated with DOACs and less parenchymal brain lesions, and also some signs of less severity in the presentation, like seizures and this type of presentation. So there are differences, indeed, and of course, in the final analysis, this will be all studied in more detail, and sub-analysis also on the risk factors and other possible differences across the groups will be more taken in account in more more detail.
Yeah. Fantastic work. It's a huge achievement to have such a large sample of patients with CVT. It's been an area where high quality data has been lacking for so long, and you're really helping all of your colleagues, I think, giving us the information we need to make rational decisions. So thank you so much again.
Thank you.
Annemijn, over to you.
Yeah, beautiful work, and not to make it too simple, but maybe in this case less is more, less anticoagulation. And well, that also brings me to Professor Caso, Valeria. We were already discussing what's the highlight from so many nice trials, and then the word resources came up. So.
Yeah, thank you, Annemijn. So I was very impressed by the nurse-led trial Optimist about the less intensive monitoring in patients with stroke, undergoing thrombolysis and NIH less than 10. So I think what I was impressed, first of all, the quality of the trial, nurse-led trial. When I started, we had all academic trials. So now to see more and more nurse-led trials is so important, because we know that the quality of our work is done by the nurses. Every day they are together with the patients. And again, less is more. We saw that the less monitoring is superior, so it's not necessary. It's not inferior. It's not necessary to stay there. And I think a patient who feels less sick, not so intensively watched in an intensive care unit, feel that he or she can make it. And also, and you know, I work a lot with low and middle income countries. I know that resources is the first problem, because you can find a donor for an MRI, you can find a donor for a monitor, but you cannot find somebody who pays you a person, high qualified person. So if you can prioritize your resources based on what you have, so example, very severe stroke, M1 occlusion, okay, then you need all the resources, intensive monitoring. But if you have an NIH 10, and we know there's also a spontaneous improvement despite thrombolysis, and you know, a patient, when he or she feels less sick, it's already something that makes you feel better and improve your health situation.
And so would you now implement this in Italy?
Absolutely, because you know, we are considered a high income country, but we have a lot of problem with our public healthcare system, and what we see, that is tough. Many of our wonderful nurses leave Italy because they are not so well paid like in other countries, and I lost a lot of good people. So I have really to prioritize. This is for me the first thing, because first point, I still want to give the best care to my patient, but I have to be realistic with the resources that I have.
Yes, and so this is one of the main takeaways I had from the session. Less is more. So less monitoring, and so when we come to the home visits and the rehabilitation, what did you think of that study?
Yeah, that was very interesting. I expected more, honestly. This is a very difficult domain about the perception, because you saw also that the ranking, the functional outcome was better, but the prompts were low. So we have to understand where's the gap. the perception of quality, how they feel, how they felt, how they were follow up. Because, you know, and they say this very well, the European Action Plan wants to take care about life after stroke. Yeah. And here is a missing point. We do well in acute care, we have everything structured, but after, this was a tentative. It doesn't mean that we will not see better or more structured results, yeah. But I think it's very important.
Completely agree. I mean, a big takeaway from me from the last 3 trials in particular, firstly was how well they were all done.
Yes.
So the quality of those trials was excellent. The data they produced was excellent. Yeah. Also, coming back to your theme and your point about the nurse-led trial for nursing monitoring after IVTs. So we had, I think, 4 trials in that session. That's from 9
great, yeah.
that were led from non-medical leaders, which is wonderful to see. And then all of them addressing very pragmatic questions, very important questions for clinical practice that our patients and their families and the patient support groups tell us are really important to them. And perhaps the rehabilitation trials towards the end were maybe a little bit disappointing in terms of the outcome. I think some of the presenters mentioned that. But I think it does give us guidance, you know. Yeah. So very, very helpful. The Norwegian trial at the very end, last long. I think that tells us something. You know, maybe it is not the best way to invest all of our very heavily in resources, at least to that group of patients that were included in that particular trial. And one of the other themes that struck me from several of the trials that were presented towards the end were, for one reason or another, the patients that were included tend to be patients with milder stroke. Yeah. So maybe these are not the people perhaps who need that extra intensity of community care thereafter. And the other point that struck me was the stroke care intervention. Many of the interventions were focused on secondary prevention.
Yeah, and not so much.
But the follow-up was relatively short. Yeah. So maybe it was too short to see the harvest, the dividend and the benefit of those interventions. Yeah. I don't know, you know, what your thoughts were on some of those points.
They showed us, I think, the feasibility, no? That was the most important point. So I think they start to show it can be done.
Correct.
We have, you know, we did it at the beginning also with acute stroke. We did so many trials that were failures. Yes. And then we learned to do the right trial. And probably now we are... This was feasible. Now we have to find the right patient for the, as you said, maybe more severe patient, M1 occlusion, MRS 3.5, 4, something like this. Yeah. So these are the patients who certainly will benefit and feel less alone.
Yeah. Yeah, and I would definitely say about these sessions, these trials were definitely not failures. They're learning us so much new lessons.
Absolutely.
Especially the methods were very sound.
Excellent.
Yes.
Completely
and it's in clinical practice, it is difficult to do less sometimes.
Yeah. And guiding, as you say, Valeria, our resources are not infinite. So if we have high quality evidence guiding us to the best way to target our resources, that's very, very helpful. So I think all of the leads should be congratulated on
absolutely,
their work.
Always.
Yeah. And we had 2 acute trials from China, both giving us very interesting results. What did you think of those, Annemijn?
So I was thinking about where are we now with tenecteplase? Are we there yet? I don't know how the other European countries are thinking about it, but we're slowly implementing it in the Netherlands. I also hope to implement it soon in my new hospital in Rotterdam. I don't know, where are you in your countries?
We have the approval from IFA. We have an approval, but now is the next step. Now they have to go to the regions, then they have to go to the hospitals, and so on and so on. We are so ready. We want to do it. But it's slow. Bureaucracy, unfortunately, is slow.
And in Portugal?
Yes, in Portugal we also have a plan to have later this year, probably by the summer or so, an approval. And we are already also at the National Stroke Society and together with our colleagues that coordinate stroke units, planning the implementation and discussions together how to do it. So we look forward also to that specific change in daily care for our patients.
So that was my thought for this trial. We're really moving from the evidence to the implementation, which is a great step, I think. Another easy one.
One thing that I thought was curious and very interesting as well was the mismatch between the results of Bridge TNK and the previous trials and the meta-analysis, the IRIS meta-analysis from the previous trials that had used intravenous alteplase for bridging and failed to show such a clear signal. So I think that's a very, very interesting result and suggests that maybe we might have a role for TNK in bridging pre-EVT. So probably we need more data, I think, even though that was a very well conducted trial, a very large trial. So probably we need more trials, I would suspect, to alter practice globally.
And then, of course, there was I always struggle with the name Tirofiran trial.
I think we all say it differently, don't we? Yes.
The truth is I haven't really wrapped my head around it. It is a promising result, absolutely.
We start using it together with stenting after thrombolysis. So I think it's a very positive result.
Yes. What did you think about it?
Well, yes, very interesting result. Seemed to be safe. Effect size remarkably similar to the Bridge TNK trial, so 20% improvement in excellent functional outcome at 90 days. So that seems to be a real signal. So an exciting result, I think. Again, I'll be interested in seeing the detail in the paper. So a fantastic roundup there, and for our next discussion we are going to move on to the Distal and MEVO trials.
So welcome back in the TV studio. So another important session today, and we have some great guests again. Here we have Marius from Bern. I'm not going to pronounce your last name, it's too difficult, sorry, and Wang. Very welcome. We're going to start talking about the MEVOs. We've already heard so much about it. But let's start with the update of the Distal. Can you tell us something about it, your highlights, your takeaways? Where do we go from here?
Well, as you know, the trial was neutral. We presented that back in February. But I think one of the highlights of today's presentations was our sub-analysis. That's completely objective, obviously, right? I'm not biased towards that. No, but I think it's an important analysis that we did, watching after, also the imaging part of our patients. And what Kati from our team really nicely presented was that we were able to save more brain in the patients that received EVT. So even in this very specific group of patients that we analyzed or we included in the trial, as you know, patient selection was a topic among all trials, so I think this is something that we can discuss. But in this specific group, we still see a benefit for imaging from EVT. So I think this is an important message.
Yes, and one of the other messages, not from the Distal trial, but I still wanted to bring it up to you as well, came from Michael Hill. He repeated it many times, that Back to the Future and that we need to be fast. Yes. Can you tell me something about timing?
Yeah. Tan, you want to elaborate on that? Shall I?
Yeah, please.
So Michael presented their sub-analysis of the ESCAPE-MEVO trial. And what they found is that in the really early time window, so under 3 hours, there is actually a benefit from EVT compared to BMT alone. So that is a reminder of time is brain, obviously. And that in their specific group, they can see a difference in MRS outcomes in the really early window. Mm-hmm. And I think this is an important message to everybody in the world, actually, not only in Europe, right? That we still are not where we should be regarding times and stroke treatment. If you see the Distal trial, we had a imaging to groin time of 70 minutes. This is just too long. And it's the same in the Escape MEVO trial. They had a door to groin time of 90 minutes. This is just, more than in the LVO trials. And there are probably a lot of reasons for that, but still I think we have to work on, having systems that are faster. And one of my hobbies is, direct to angio, getting faster. We're launching now a trial on, call it Get Fast actually, randomized trial on going directly to the angio. But I think, just one trial or two trials won't help. We have as a community have to start thinking about having a pathway that leads this patient directly to the best room, and I think it's going to be the angio.
Absolutely. I think you're so right there, Marius. I mean, one of the things that really struck me when I read those two papers was how similar the findings were for the two trials. Remarkably consistent evidence. That said, they weren't identical trials. Tan, what's your overall take on the two trials and related data? Maybe key differences?
Sure.
What do you think?
Between Distal and Escape MEVO, some key differences in terms of starting with technique. The Escape MEVO was a stent retriever-based trial, so all stent retrievers, just the Medtronic stent retriever was the main technique to open up the arteries, whereas Distal was more permissive. Any approved device could be included in the trial.
Right.
The time window of enrollment was a little bit different. Escape MEVO was up to 12 hours, and Distal was
Up to 24.
24 hours, so a little bit longer in Distal, so we can see some differences there. Perfusion imaging was not mandatory in Escape MEVO. If you obtain it, then it, of course, would be recorded and then analyzed. And then after 6 hours, I believe it was mandatory in Distal. So a few differences in patient selection.
Yeah.
The entry for severity of disease, pretty similar between the two trials, almost, if
Yeah.
not identical.
Yeah.
So I think that's the difference between these two trials and other trials of MEVO that are currently, ongoing or completed.
Yeah. Marius, Distal allowed A1s and P1s while Escape MEVO didn't. Do you think that made any? Do you guys think that made any appreciable difference to the results of the trials?
No, I don't think so. It's a really small portion of our patient collective, and so I don't think that made any difference.
Yeah.
Yeah, they're pretty uncommon. I think the concern in Escape MEVO is that P1 is almost like an LVO because they often have motor symptoms with the brainstem going, being affected. So that's probably why they excluded it from Escape MEVO.
Yeah. And the other signal that really jumped out at me then was from Michael's presentation this morning. So, he really emphasized that, and it was highly statistically significant, that interaction by time and, jumping back to what you were saying there about the need for speed and the need to get these patients straight into the cath lab. So is there room, therefore, for maybe another, Distal 2, Escape MEVO 2, just a faster one, or possibly focusing on patients with a sweet spot of more severe stroke? There was a tendency towards benefit, a directional tendency towards benefit in patients with an NIH of 10 or more in Distal, right? Mm-hmm. So I thought that was very interesting.
Do you have any information, maybe? Are you
I don't know. I don't
watching
know.
over emails? No,
I mean, just wondering, though.
Yeah, that's. I think that's a logical step for the whole community. Like,
Yeah.
we had 2 trials or 3 with discount that were very broad in their inclusion criteria.
Right.
And so now we can make more analysis on the broad population and try to find a group of patients that will profit probably from this treatment. I can maybe disclose already that we have looked into time. It doesn't seem to be as relevant in the Distal group, although we haven't finalized this evaluation. And one thing that seems to be highly relevant is imaging. So I think a future trial, if you want to call it Distal 2, or I don't know how we're going to call it, is probably going to have an inclusion criteria based on imaging. We have seen that in patients that have an NIHs of over 6 and a Tmax 6 at baseline of over 60, there is a really significant treatment effect there. It's a small group. The trial was not powered for this answer, right? But still, we can take and extract some information and maybe plan the next trial based on such criteria.
Yes. What are your thoughts, Dan, on more selective targeting of these islands of patients within the overall Distal and MEVO trials that may derive benefit?
Great question, Peter. So there's the Oriental MEVO trial, which is enrolling already patients with higher severity of NIHSS, so you have to be 6 or greater, whereas Escape MEVO and Distal allowed as low as 3 with other disabling symptoms. They've completed enrollment in that trial, so it remains to be seen if they'll be positive or not. I don't know the results, but I think that'll be really interesting to see, like, does that change practice? And will that be enough to say, okay, we have a positive trial for these higher severity, so do we need to replicate Distal or Escape MEVO for the higher severity if we have one potential trial coming out of China? So that's a big question that remains to be seen. There's the Distal's trial, which is looking at imaging endpoints for the reperfusion with devices compared to medical care. And so I think we need to learn a little bit more from that before probably you launch into your next Distal 2 trial.
Yeah, and I think maybe until then, sorry.
No, you go ahead.
Maybe until then, that's something I'm going to talk about in the evening. Also, my idea right now is, like, you have to have a really good risk-reward evaluation of those patients in your mind as a stroke physician. And I think maybe a comparison is a little bit like the stock market, right? Something that we can understand. Like, if you have an LVO, that's like your blue chip, Okay. The risk is probably low and the reward can be really high. If you have a MEVO with a really low Tmax and a really low NIHSS, that's like, a penny stock where you can lose a lot and the reward is probably really low in the majority of the cases. So I think this is something that maybe we should not, go all the way, do 6 passes with every possible stent retriever.
Yeah, I mean, we already have some signals from the Hermes subgroup analysis by Bijoy Menon et al. It was published in JNIS, where patients with M2 occlusions with a median NIH stroke scale of 14 to 15, that subgroup showed positive benefit of thrombectomy. So they were much higher severity. Yeah. So the question is, do you really need this perfusion imaging to select patients if the patient's already coming at higher severity? And that's a big question in itself, where Hermes didn't, it didn't matter, these patients benefited because they were just so severe. Yeah. And then just having been a participant in the Escape MEVO, we looked at some of these patients who were medically managed. And of those that we enrolled who had lower severity, I was astonished at how well they did on medical management. Their MRS at 90 days, easily 0 to 1. So medical management shouldn't be underestimated. It's not easy to beat with thrombectomy. So I think we need to really consider the medical part is not easy to beat as opposed to someone who has LVO, where they're much more severe. Yeah.
And then there's this one question left. What should we do about the collaterals?
Yeah.
It's a really interesting question. I mean, Michael showed some slides on his or their collateral analysis. They showed that people that had better collaterals tended to have a better therapeutic effect with EVT, and I think this is also an important point. Like, is it maybe that MEVOs have worse collaterals over time than an LVO, or they behave differently, so the decay is faster, and that maybe brings us back to the time point, right? So even if the patient has good collaterals, maybe we have to be faster than a similar patient, LVO patient, that can have a longer decay of the tissue at risk to an infarct.
Yeah, and then this was also already mentioned, but then is there like a three-way interaction between all these factors?
Yeah, probably.
Yes. Yeah.
Yeah, so I am going to bridge right over to segue over to Bridge TNK. Congratulations on that trial. Can you tell us a little bit about it and your interpretation, and how does it fit in with the previous data we have from the IRIS meta-analysis?
Yeah, thank you, Peter. So it was really a team effort from our colleagues in China, Zhang Mingqiu, Qingwu Yang, Wenji Zi, and Guangsong Yang. They all presented the trial. on behalf of the team. So it was looking at tenecteplase prior to thrombectomy with large vessel occlusion compared to no tenecteplase prior to large vessel occlusion thrombectomy. And this was within the 4.5-hour window. So pretty similar to the patients that were enrolled in IRIS, except for the point that these patients had tenecteplase, whereas almost all patients in the IRIS were alteplase, except for direct safe, which had a few patients with tenecteplase. So it's a very different drug. The drug was from China, the TNK version in China. And essentially what it showed was that the patients who were in the intervention group, which was receiving the bridge, they did better than those who did not receive tenecteplase, and it was highly significant, supporting the idea that we should give TNK to these patients who are presenting direct to these EVT centers. And all patients in this trial were directly presenting to the EVT center. We didn't have patients who were at the outside hospital. And so, again, all patients who come to the outside hospital should still get the drug that they're eligible for.
Yep, yep. So how do we interpret this with the previous, perhaps inconclusive alteplase trials? And what are your thoughts on why the signal is different?
Yeah, it's a terrific question. So the alteplase trials, they showed that there was superiority in the Kaismacher meta-analysis. They showed there was superiority of the drug prior to thrombectomy in the early time window, so 2.5 hours, whereas after there was almost like a ceiling effect, or they couldn't prove it that it was beneficial. Whereas in this trial, actually, the patients in the early group seem to do better with thrombectomy alone. So, they just go so fast that there's not much more to save after that early one. So it's kind of contradictory to itself.
Yeah.
So I think we still need to digest the data, but it depends on what you have available at your hospital. So if you have alteplase, then you get alteplase. If you have tenecteplase, you get tenecteplase. But if you have the choice between the two, then it would seem reasonable to go with tenecteplase because it's showing superiority, over the overall 4.5-hour time window.
Yeah.
So that's a major consideration.
Yeah.
And then in terms of your question of differences, why is it positive? The tenecteplase seems to be more fibrin specific, has been shown to maybe have better recanalization results than alteplase. And so I think that's why we're maybe seeing a better signal
and
here.
quicker to give, when we're trying to get people into the lab, right, into the cath lab.
Yeah.
So it might be as simple as that, perhaps, and back to speed again. So I think the main take-home is do not withhold the thrombolytics in patients with LVO on the way to EVT.
And maybe
right?
they even have a use for really distal occlusions, right? So this is something, as the next bridge now.
Bridge 2.
Bridge number 2.
Bridge 2.
We can easier give it also intraarterially.
Right.
For us, it's a use that we do for Techno, for example, for the Techno trial.
Yeah.
And we also think that maybe there is a use for those SIM4 occlusions that, of course, we can, or the star interventionalists can navigate there, right?
Yeah.
But you don't have the star interventionalists every night and every weekend in the hospital. So maybe, when you have a young fellow that's not so experienced, it's better to give some TNK intraarterially.
Yeah.
So this is something we have to test in future trials.
Yeah, fantastic steps forward today. Well, with that, we'll wrap up our midday highlight session of ESO TV. Once again, I'd like to thank my co-host, Annemijn Algra, Thanh Nguyen, Marius T. Kogias. Enjoy the rest of the conference.